Yeah, I mean, I started my talk by saying that we're waiting way too late for people to be treated. We're waiting for people to have symptoms, then we react to it and we say, oh, okay, now I'm going to treat you. And if you think about it, we have really made a huge difference in early interception in many other cancers where we can really change the way we think of them and cure them. And cancer screening does save lives in other cancers. Why are we not doing it in multiple myeloma, where it's a simple blood test? It's not mammography, it's not colonoscopy. And we already know that if you treat smoldering myeloma early, you can at least make a difference in preventing fractures, anemia, renal failure. And I think all of us want to do that. And biologically, we don't need to wait for a huge tumor burden and huge clonal evolution and changes in the immune system to start treating patients. So I have not seen a single patient who tells me, let's wait until I'm really having a fracture and then treat me, please. We need to have the physicians think of it in a different way. If I have multiple myeloma today, I would rather have known about it 4 or 5 years ago and treated it earlier before I get the renal failure or the fracture or the anemia. And we really need to come to a point where cancer screening, early interception can potentially make a difference in our treatment. So screening them early and finding who's at risk, then risk stratifying them by correctly understanding who is going to develop myeloma, and then intercepting early and not using the same drugs that we use in myeloma, but bringing them in an innovative way, what we call precision interception, so that you're not treating every smoldering or every MGUS in the same way, and potentially bringing immunotherapy early, because that's the best thing. Harness your own immune system against a very small tumor clone to make a big difference for those patients.